Right. Okay. You can start recording, no, Sindhupa? So, yeah,
Yeah, Prem, you can start. Yeah.
all cool, right? Okay. So, yeah, hi, guys. So, I'm Premjit. So, basically this preparatory course, like Dr. Sindhupa said, probably it's going to be the last one. So, what I actually thought was skin, which is very, very important. Okay. And you might probably, as far as I know, you will get like around 30 true, I mean, this best out of 5, and the remaining will be your true false. So at least 5 or 4 out of the entire thing is going to be about skin, right? So what I actually thought was, instead of rather going a lot about the theory, I just thought we'll discuss a few questions, like not a few. What I have made is I've made around 90 questions, and I know that there's very less time available. So I thought we'll just try to finish as much as we can, because all those 90 are like the entire 90 is very important. And I've made it in such a way that once you are done with that 90 questions, you don't have to read anything on skin. You just have to take this recording, and then once you travel on your in your car or whatever, just listen to it, and that's about it. You don't need to even open the book again on skin. All right. So just pay attention and pay focus, because all the questions are going to be about pictures, and every point that I'm going to say, just take it in your mind. And since you're going to get the recording, listen to it again, because all those points, like every point is an MCQ point, because I'm not going to go anything extra, right? Not going to waste time, just going to go with points, which is very important. All right. Okay. So before anything, like I said, I'm not going to go too much about pathophysiology or anything about skin. It's going to be full and full exam oriented, right? Okay. So here you see, this is just a very small basic that you need to know before you even read what skin pathology and the diseases are, right? So like you see in this picture, it's, I mean, everyone can see the picture, right? And I'm audible as well, right? Yeah.
Yes.
Saumya Varnakula Surya, am I audible?
Prem, yes, you're audible.
Yeah, fine. Okay. So now this, like you see in this picture, you see the uppermost layer is very, very important. It's going to help us in many ways, and that's the epidermis. And it has 5 layers. You know, we have a small formula called CLGSB. Okay. And stratum, it starts with the stratum corneum, lucidum, granulosum. That's CLG, and spinosum and basal. This is so important because you see these 5 layers in the epidermis, and then comes the dermis, right? Whatever lesions that are arising from the epidermis, which is the very fragile one, it's going to be so, like, it can easily break off. And whatever is going to come from the dermo-epidermal junction or from the dermis is going to be very hard. So it's not, you can't break it easily. So just keep that in mind. 5 layers in your epidermis, that's CLGSB, and the dermis, right? Okay. So before we go into certain things, because all the terms that we're going to use in skin is going to be like papule, pustule, and those things. So you need to actually know what exactly those things are. I'll just give you an example. What is a papule? You see the skin, if there is a small, just like, you have seen this prickly heat where kids or anyone comes to you. So these small raised lesions, which is less than 0.5 centimeter, is called a papule, right? Remember, a papule is something that is 0.5 centimeters, less than 0.5 raised, it's called papule. And if it is more than 0.5, let's say the cutoff is 1 centimeter, and if it is more than that, still just a small dot raised from the skin is called a nodule, right? So that is done. And then, what do you mean by macule? So, like I said, the skin, a small raised one is a papule or a nodule, something that is not raised at all, right? Not at all raised, just flat with the skin. It's just with the skin, not raised. And if it is less than 1 centimeter, you call it a macule. And if it is more than 1 centimeter, you call it as a patch, right? A patch is something not raised, flat with the skin, a lesion over the skin, which is more than 1 centimeter, right? The other one that we have to know is, what is the difference between a vesicle and a bulla? A vesicle is something that is filled with water, liquid, right? And that is less than 1 centimeter. A small, a fluid-filled sac is called a vesicle. And if it comes more than 1 centimeter, we call it as a bulla. And if that bulla or a vesicle contains pus, we call that as a pustule. All right. So these are very important. And one very important one is you have learned the patch. I told you, not at all raised, non-raised lesion on your skin, just like this. A bigger version is called a patch. And if that patch is raised above the skin, and then again, if it is more than 1 centimeter, we call it as a plaque, right? So now you know plaques, what we see in psoriasis, it's a raised from the skin and more than 1 centimeter. The remaining, you don't have to worry, which is there in the screen. Just forget about it. So let's go directly to the question. And I would want everyone to participate in this. And since we don't have time, I want to finish so many questions in the 2 hour time. It's going to be so interesting because we'll just do it fast and just keep focus on one. Let's start with the first candidate, Saumya Varnakula Surya. You have 30 seconds for this question, right? Just read this question and I will just show you, yes, this is the lesion and these are the options. Your 30 seconds starts now. Saumya, can you switch on your mic, please? Saumya? Dr. Saumya? I mean, see, one more thing you have to understand is this exam is, I mean, this class is not to actually check your knowledge, whether you know or not. I'll be very happy if you don't know, because I'm always here to help you out. And, you know, if you make a mistake, I'm always here to help you because you're just studying, you're knowing how to approach the exam. Okay. So without wasting time, Saumya, can you just on your mic only, not the video, please? So can we go to the next person, please? Taniswaran, can you switch on your mic? Please don't waste time because I want everyone to participate in this. You know, please make mistakes. I'll be very happy if you make a mistake. Okay, right? Okay, Taniswaran, you can hear me, right?
Yeah.
Yeah, please. Yeah, thank you very much. Can you please read the question? You have 30 seconds, and let's discuss inside out. Don't worry. Please make mistakes. I'm happy if you make mistakes, right? Okay, go ahead. You have 30 seconds. I put the stem very small so that, you know, you can take, you know, quick time and, you know, that will be a very good practice for your brain. You stimulate your brain so much that you can read a lot. All right. Okay. Your 30 seconds starts now. It's fine. It's done. Just tell whatever comes in your mind, please.
The first one I have read in articles, like I couldn't pronounce that one, but I have read in articles that
Okay.
first one is the answer.
So you're telling that the first one is that means the Caucasians, is it?
Oh yeah.
Okay. So I'm very happy that you came across this, but we have to know one thing. Actually, this type of melanoma, I think we did a class on this. This acral lentiginous melanoma is very, very rare in Caucasians, right? Caucasians is the white people that we are talking about. Okay. So the answer here is it is actually found in Asians. Okay. So don't worry, just pay focus on it. I'll just try to talk to you about all the types of melanomas. And this specific type of acral lentiginous melanoma that we just discussed is very, very common in Asians. And there's a nice story behind this. You might all have heard about this singer called Bob Marley, right? So Bob Marley died at a younger age, that is 36 years of age, and he died with this acral lentiginous melanoma. Because, you know, why it is so rare? Because it is, you know, you don't see the black mole or whatever on your skin. These lesions are very common on your fingertips, sides of your fingers, and under your nails, subungual, right? So this kind of rare one is seen in, I mean, this acral lentiginous and found more in Asians, right? So, like I told you, the melanomas, you all know the types, and every point is an MCQ, all right? The commonest one, you know, there are 4 types. There are a lot of types, but the 4 most important type, the first one is something called superficially spreading one. It spreads superficially, and mostly it is seen in sun exposed areas like face, you know, arms, people's like legs, and on the back if they, you know, go to the beach quite often. 70% of your melanoma is superficial spreading, MCQ. All right, 70% of your melanomas. So the second most common is a nodular. I just explained, more than 1 centimeter raised from your skin is a nodule. A nodular blackish lesion, always suspect a melanoma. That is also seen in sun exposed areas and seen in middle or even aged people. Number 2. Number 3, like I told you, this lentigo maligna. So that is the third type, which is a less common one. And it is also seen in the very, very chronic, chronically sun exposed areas, and mostly seen in older people. So the first 2 types, superficial spreading and nodular, both are seen in young to middle-aged, and lentigo is seen in older people. And the last common type is what we discussed now, is acral lentiginous, which is seen in Asians, and it is very common in the soles, palm, and the sides of the fingers and the nails. All right. Okay. So how do you detect melanoma? You see this picture on your screen. It is so asymmetry. See the melanoma down. The lesion is asymmetry. It is not symmetrical, and the borders are very uneven. Multiple colors: black, brown, red. So many things are there. So then again, MCQ. What are the major criteria to diagnose melanoma? 3 criteria: change in the color, change in the size, change in the shape. 3 things. All right. Remember everything when I say MCQ, just remember that. So you see all these features in this. The next one is the minor criteria, which is altered sensation, suddenly oozing, bleeding, inflammation on a previous mole is a very, very, a red flag sign. All right. How do you treat this melanoma? You know that it can spread. So immediately you need to do something called an excisional biopsy. What do you mean by excisional biopsy? Let's say that this portion is having a melanoma. You cut open the entire thing and you take it off. You don't take only the borders. You don't do a punch biopsy. You don't just put it and rotate and take it. You don't do that. You take the entire thing. That is when we can actually see the borders and the sides and the depth, etc. All right, that is very important. And once the pathology is confirmed, then we can actually go for more thickness. And one important another MCQ point: the margins. This melanoma, like I said, the margins, it all depends on one thing: how many centimeters you need to take. Is it 1 centimeter, or is it 2 centimeters? Is it 3 centimeters? Everything depends on something called Breslow thickness. All right, Breslow thickness. And this is one of the conditions where you actually take the sentinel lymph node to do a biopsy. All right, just like your breast carcinoma, melanoma is one. This is an MCQ. 2 things: breast and your melanomas, where you do a sentinel lymph node biopsy. Okay, let's quickly go to the next one. All right. So next one, Charuhashini, can you actually go through this, please? Yeah. You have like 30 seconds. Quickly, don't have to worry at all. It's so easy. Charuhashini, please. You all have to switch on your mics, because I worked very hard for this thing, and I really appreciate if you make mistakes. All right, because this is the platform for you to make mistakes and learn, and I'm always here to help you. Start. Don't waste time. Just start. Yeah. Charuhashini, you can hear me, right? Siva Prakasam, Siva Prashant, Charuhashini. Because there's no point in me just reading. Nothing will actually go in your mind. Please actually switch on your mic, and we're actually wasting time. It's going to benefit you all, that's why. So please. So can we go to the next one? Kavya Gunavardhana.
Give me a minute to read it.
Yeah, no problem. Please, yeah. Can we just stop? It's okay, no problem. Just yeah. Because and please, I'm happy if you make mistakes, okay? Because that's fine. Yeah. Can you just go ahead what the answer is? And I'm anyway going to put the answer next. Yeah.
So the side effects.
Okay.
Okay.
Okay. Good. You're thinking about the fine side effects. Okay. And then what do you think can be the option here? Okay, no problem, no problem. I'm here to help you. I'm happy that at least you came forward, right? So this is actually, I'll tell you 1 second, just give me a minute. Yeah. So here the treatment is continued up to 1 year. I'll tell you the reason. All right. Okay. So here they were using only, you can see me, right, everybody? Oh, yeah, you can see. Yeah, fine. Yeah. So the treatment should be continued for 1 year. What the reason why I'm telling you this is because this, what do you call this? Fungal infections, right? Is very, very notorious and so bad that you can't treat for like 2 months or 3 months if you're using a local application. If you're using oral, that's fine. Local application has to be taken for 1 entire year. That is why this fungus is very, very notorious. And I'll talk to you about this fungal infection. Another name for the fungal infection, which are the dirty nails like this, is called as onychomycosis. You know that. And always this fungal infection starts from the side of the nail and goes inward, right? MCQ. Another important thing is there are 2 important causes of this. One is dermatophytes. 90% of the cases are due to something called trichophyton rubrum. T. rubrum. Very, very important. That is 90%, and it's a dermatophyte. And the remaining 10% of the cases are candida, right? Okay. And you know these risk factors are there. As usual, it's diabetes, psoriasis, and increasing age and repeated nail trauma. These are the 4 things that can cause this problem. Okay. And what are the features actually? When you see this nails, which are very thick, rough, very opaque, these are the ones that actually are the main features. Okay, right. And what is the investigation? And you need to know this is an important MCQ. When you get a fungal infection on your skin, it is a clinical diagnosis. You actually don't do any investigation. You just start treatment. But when it comes to the nail infection, fungal nail, you have to take the nail clipping and then only you need to start treatment. All right? Okay. How do you start treatment and how do you decide? If the nail, if less than 50% of the nail is affected, okay? If it is less than 50% and less than 2, that means 2 or 1 nail is involved, then you can actually use local application, that is topical form. There are 2 important ones, that is amarolfin, okay, amarolfin, or there is a lot of things called dactyrin tincture. All these things have to be continued for 1 year. All right? Okay. Suppose, let's say, if it is more than 50% and there is more extensive, then you need to use oral treatment, and the drug of choice is oral terbinafine, which is given from 6 weeks to 3 months is the therapy. All right. And 6 weeks to 3 months is given for your fingers. And if it is your nail, half, then the topical, that is 6 months. All right. Okay. These 2, know it, very important. Terbinafine, the drug of choice. If you're suspecting, let's say, candida infection, then you need to give itraconazole, which is the drug of choice for this. And also there is something called pulse therapy. Pulse therapy is basically you give 1 week of itraconazole, 3 weeks off. Again, 1 week, 3 weeks off, right? You give this pulse therapy three pulses. That means 1 week treatment, 3 weeks off. 1 week treatment, 3 weeks off. 3 times like this for the toenails and twice for your fingernails. All right. So every point I'm telling, just keep it in your mind. Everything is an MCQ. All right. Shall we go to the next one, please? 1 second. Yeah. Can someone please don't waste time? Just, Nusha, Nazar, can you please, switch on your mic, because I'm here to help you. You don't have to even, what do you say? Answer. I'm here to answer anyways. Yeah. Can you read this, please? Yeah. Nusha? Can you please switch on the mics, because I have to know that you all are even listening, because I mean, I'm not even asking you questions. I'm just wanting to read this. That's all. Please. Nusha? Oh, sir, can someone please, I mean, volunteer and just read this. That's all. Please. Pamudi Mendes?
Okay, sir.
Yeah, please. Just read it loud, so that others can listen, please. Yeah.
A 50, sorry, a 57-year-old man attends with a cough. He is otherwise well and not on any regular medications. At the end of the consultation, he asks if you could have a quick look at his toenail. It has changed appearance and he doesn't know why. There has been no history of trauma. The nail of the right hallucis is yellow and thickened at the lateral edge. The skin of his feet appears healthy. The nail doesn't cause him any symptoms and he does not bothered by it. He just wants to know what is it. What is the first line management options to suggest in this case?
Okay, no problem. I'll guide you. Okay, fine. Now the options are here. So first option is check the liver function test and prescribe an oral antifungal such as terbinafine, right? Okay. Now, one thing you have to understand in this patient, you can see that he says that it's not bothering him, right? The symptoms, there are no symptoms, not bothering, and probably it is just in the lateral edge. I told you, less than 50%. Don't go for oral. So the first option is out of the picture. All right. And
Okay.
one more MCQ in the first option is check the liver function and prescribe oral antifungal such as terbinafine. You should know, this is an MCQ, that terbinafine is the safest drug that you can give, and the liver functions is not very urgently checked. All right. Very important. So this is out of the picture. We don't give oral antifungal because the patient doesn't have any symptoms. Second one, no treatment necessary if he's happy to leave it. Yes, that is the answer. So I didn't get you, Pamudi. Yes?
I would like to take that stem
Super.
as the
Very
answer.
good. Very good. Very good. So that is the answer, because less than 50% of the nail involvement, fungus, not bothering anything, no problems. Please tell the patient, go happily, go home. Okay? Right. Third one, refer to a podiatry. Podiatrist is someone that takes care of your feet and nails regularly, mostly recommended by doctors. I mean, if the patient is a diabetic, and then we actually recommend. But here, it is not needed. We just tell the patient to go home happily, so not needed. Fourth option, swab the skin for microscopy and culture. This is not skin. We are talking about the nail. And then again, if you're starting treatment, you have to go for a nail clipping, not a skin. All right? Okay.
Yes.
And the next one, the last one, is over-the-counter topical antifungal treatment. It's not given. Sorry. It is not given because this patient, like I told you, it's very, I mean, small, less than 50, just the lateral edge. He is happy to do his work. So do not give anything. Just send the patient home, right? So you guys are now thorough with the fungal infections. And one more MCQ point that I need to teach you all is that if you get a nail, okay, a nail that is so dirty, always don't think of fungus only. It can be onychomycosis, that is what we just saw. It can be psoriatic nail, number 2. It can be repeated trauma, number 3. And number 4, it can be lichen planus. These 4 things, I will explain lichen planus later. So it's an MCQ. What are the differential diagnoses of skin opacity and dirty nails? 4 things I have mentioned. Keep it in your mind. Good. Shall we go to the next one? Right. So you're correct. Whoever answered this, excellent. Right. Next one. Right. Okay. So please, someone just read. I'm not telling you to even answer. Please volunteer this, someone, please. Soumya or Charuhashini, Nusha, someone, please, just read that. It's enough. Just a question. Go ahead. Quickly. Yeah. Nusha? Yeah, Charuhashini, good. Just read the question quickly. Don't waste time, because I'm working this for you only. It's going to help you, not me. So please read it. Yeah, quickly. Yeah. Go ahead. Just be loud. Are you there?
A 24-year-old woman.
Yeah, 24-year-old woman presents.
Yeah. He has olive skin, dark
Right. Okay.
brown.
Okay. Menstrual cycles are regular. 33. Okay. Not heavy, not painful. Okay. She's slim build. And what is the most likely diagnosis? Okay, guys. Now you see there is a lot of hair in a in a female. So it is basically in a male pattern androgen dependent hair, right? Okay. So this is something called as hirsutism and not hypertrichosis. What is the difference between hypertrichosis and hirsutism? Right. Okay. Let's go with the first option. Increased hair growth post shaving. Right. So, I mean, obviously there should be a reason for her to shave, right? It didn't just come like that. She didn't just shave it. She had this hair and she shaved it. So why did this come? So next we are talking about genetic phenotype. Okay, we'll just keep that aside. And then we're talking about third option, which is hypertrichosis, right? So the difference between hypertrichosis and hirsutism. Hypertrichosis can come to a male or a female, anybody. Why? Because it is androgen independent. It is not dependent on androgen, not dependent on the male hormone or whatever. It is androgen independent, can occur anywhere in the body, even the face. I mean, face, hand, legs, anywhere. And hirsutism is something that is caused with androgen dependent areas in a female, just like how you saw now in the tummy, probably under this neck, etc., etc. Right. So now you got the difference. And how does this hypertrichosis is caused? It's caused by variety of things like severe dehydration. And patient is, this disorder called anorexia nervosa. Patient is dehydrated, fasting, and excessive stress to the body brings this hypertrichosis. That is one. And number two is drugs like cyclosporin, phenytoin, steroids. Three. And number three is there's a condition called porphyria cutanea tarda that also releases a few kind of chemicals, sun exposure, you get this. These three are the common causes. MCQ, what are the causes of hypertrichosis? These three are the causes. And I told you, and this is hirsutism. Okay, starting with early menopause, I don't think so. That's the answer. The last option, polycystic ovarian, could be the answer. But having said that, the question says that the patient is a bit slim. So that is out of the picture. Then again, the cycles are regular. Where polycystic ovarian, you get an irregular cycle. So that is also out of the picture. And then at the end, the cycles are around 33. So we don't have to worry. So kind of regular cycles, not causing any painful, no menorrhagia, nothing. So this is a genetic phenotype of hirsutism. So hirsutism, like I said, it can be acquired or congenital. Congenital means the causes, congenital adrenal hyperplasia or something that is causing a problem on your adrenals and releasing this androgen. Adrenal hyperplasia, adrenal tumors, something devastating the adrenal glands, and also the pituitary tumors. All these which can increase the androgens in a female is hirsutism. All right, done. So, okay. So I hope okay, fine. So that's the answer. And I told you this thing. Okay. So please, someone, Varuna Sampath, can you please just read it? It's enough. Okay.
A 2-year-old boy is with the persistence cap above his right ear.
Okay. Actually, this is not the right ear. It is much, somewhere in the scalp. Okay, go ahead. Go ahead, Varuna.
His mother reports that it has slowly developed over the past few weeks and initially started out as a patch of dandruff. He is systemically well and there is no past medical history of note. The lesion is shown below. What is the most likely diagnosis?
Right. So, okay, thank you, Varuna. I'm here to help you out with this question. Okay, so So basically we have these 5 options. So can we just discuss it slow by slow? I will tell you what seborrheic dermatitis is. Seborrheic dermatitis is a kind of a inflammation of your scalp. Not only your scalp, you can get your eyebrows affected, everywhere where you get this, sebum secretion. That's why it's called seborrheic, sebum secretion. And there is a inflammation and it invites some fungus, and that causes dermatitis on your scalp, on your ear brows, and in your nasolabial fold, behind your ears, on your chest, in between your chest. All these areas which can produce sebum, you get this inflammation called as seborrheic dermatitis. That is number 1. But it's trichotillomania. 1 second, I'll just show you a picture of it. It'll be easy, right? So anyways, this is actually something called a Kirian. I'll just explain it to you. So you just saw this first picture, seborrheic dermatitis. It's affecting all the areas where it is sebum enriched. Patient scratches that area. I will explain it to you the next slide. And what is trichotillomania? Trichotillomania, you see this person, a person who is, always under stress, pulling the hair, like a kind of a psychological disorder is called as trichotillomania. And impetigo, no, this condition is not impetigo. Impetigo is a bacterial infection. Most commonly you see in children around the, face, lips, even the limbs. You get this kind of a pustules, like, crusty lesion. It gets infected, become crusts. That is called impetigo. So this is also out of the picture. At the end, we are talking about scalp psoriasis, which you see in the picture. And whatever you learned, the psoriasis which you see in the hand can occur in the scalp. And one MCQ point is, how do you differentiate the seborrheic dermatitis and the scalp psoriasis? You see this hairline, right? Your hairline. Inside your hair is where you have this sebum secretion. So everything inside your scalp, you get a lesion, it is seborrheic dermatitis. And something that is outside, it is, completely coming out of your hairline. Some lesion here, some lesion here is psoriasis, but some lesion inside the scalp is seborrheic dermatitis, right? So we just learned that this condition is called Kirion. What is Kirion? Okay, I'll just get back to you. So Kirion is a type of a fungal infection of your scalp. We read, why I'm emphasizing fungal infection is it's so important, right? So we just learned the fungal infection of the nails. Now we are going to the fungal infection of the body, right? So when you get a fungal infection on your head, you call that as tinea capitis. Caput is your head, tinea capitis. And if you get a fungal infection on your body, your hands, trunk, everywhere, you call this as a tinea corporis. And then if you get a lesion, a fungal infection between your toe webs in your leg, you call that as tinea pedis. PD is leg, right? So coming back to the Kirion, we'll start from the head. So like I told you, an MCQ point, that fungal nail infection is caused by dermatophyte, trichophyton, rubrum, R. But when you talk about the scalp infection, it is also dermatophyte, but it is caused by an infection called trichophyton tonsurans. T, just imagine your tonsils. Tonsuran for your scalp, and rubra is for your nails, finger, and your legs. Okay, so you know that I told you it is trichophyton tonsurans, and there's another infection which can come from cats or dogs, which is actually called as microsporum species. We just read that dermatophytes, that is the trichophyton species, is the commonest, and the second commonest is microsporum species, where you can diagnose that with something called a Wood's light. You hit a light on that and you see a fluorescence, green fluorescence coming out of it. That is actually going towards microsporum. And if you're thinking of trichophyton species, what you can actually do is you can do a scalp, scalp scraping, scrape that and check from your microscope, and you can see some hyphae moving around. That's called trichophyton species on your scalp, right? And then now you know trichophyton and your microsporum, both are there. So trichophyton species, it goes very, very well with itraconazole or terbinafine. Okay, it is the drug of choice. If you get a scalp infection, scalp tinea, fungus, that is microsporum, the second type, the drug of choice is griseofulvin. Let's say the patient is having a chronic infection, just like this. What happens? There is so much of infection inside. It has a lot of pus formation. It becomes a boggy ball-like thing, and that is called chirion, what you see here, right? So we learned about chirion as well. Next, like I told you, everywhere in your body, that is tinea corporis, the drug of choice is oral terbinafine or itraconazole. And for your tinea pedis, that is the leg, you don't have to jump to a oral. You can actually go with local application of terbinafine or lozeril, which is amylolfin, and there is etc. etc. All these things are local application, right? Shall we go to the next one? Right. Okay. Okay. Someone, can you quickly read this? We'll quickly go now. These are very, very important. That's why I'm actually coming to this. Okay. 1 second. Right. Sorry. Right. Can somebody read this? Just read it, please.
20-year-old man
Very
presented the
good.
following
Yeah.
skin lesion.
Good.
It
Yeah.
has been there for 1 week and has been itchy and bothersome. He used
Yeah.
some hydrocortisone cream at home for a few days, which helped a little with the itching. He has otherwise been well with no recent infection or issues. What is the most likely diagnosis?
Yes, good, good. And see, now you have to know that this is kind of a, a discoid lesion. What do you mean by discoid lesion? Discoid lesion is actually a round lesion, which is just like this. So whenever you get a round lesion in the body, there are few differential diagnoses that you should think of. There is something called discoid eczema, Okay, see here. Number one is atopic dermatitis. It can still cause rounded ones. And atopic dermatitis, it usually starts from childhood. So infants, the face is affected initially, face. That is the first part affected. And when the child slowly grows to that, 2-year mark to 10-year mark, small children, you get it actually in the extensor surfaces. And then when the person becomes an adult, this atopic dermatitis goes to the flexor areas, MCQ, all right? Infant, children, elderly. And this atopic dermatitis is so itchy and it is not very roundish, kind of a oval shaped. Next, you are seeing discoid eczema. Okay, so you see this discoid eczema, it's a disc-shaped, round shape, but the entire lesion is same. It is kind of a raised, like a plaque. I told you, raised from the skin 1 centimeter. Entire thing is, you see this crust and some small, breakage of the skin, etc. is seen in discoid eczema. And why isn't this plaque psoriasis? You see this, why isn't this plaque psoriasis? See, it's not even a plaque. Plaque psoriasis is actually raised, right? See, this picture, it's raised. And so what we go with the diagnosis here is we just discussed the body fungus infection, tinea corporis. Why we say this is tinea corporis is if you see the infection, the fungus usually grows from the center, it spreads from, goes from inside to the outer areas, and the most vulnerable fungus lies in the borders. That is why your fungus infection, the borders are raised, but the center is depressed. That's why you call it as a central clearing with edges raised is called as tinea, right? And another MCQ point that you have to learn is never give steroid creams for tinea, because now you see this patient has taken hydrocortisone cream, and what has happened is this infection has become more reddish. If not, you would have seen a central clearing. The center would have been cleared, but you are seeing red inflammation a lot. That is called as tinea incognito. Tinea incognito. That means tinea corporis in the body. You use steroids, it becomes, it becomes so angry looking reddish when you use steroids. Okay, good. Shall we go to the next one? Yeah, please, someone can, quickly read this. Second. Yeah. Okay. Can someone read this quickly, please? Please don't waste time. Please just read it, I'm not even asking the answer.
Sharon is a 31-year-old woman who
Okay,
comes
good.
to see you with a 2-week history of a rash around the outside of her mouth, which is not itchy. She mentions that last month she changed the brand of foundation makeup she uses. On examination, there are grouped follicular reddish papules, vesicles, and pustules on an erythematous base around the mouth and cheeks. There is sparing of the lip margins. You suspect that this is perioral dermatitis. What is the
Right.
most appropriate management?
Good. Yes. Can you read the options as well quickly? Just the options.
Advise Sharon to stop using facial cosmetics and the rash will completely resolve. Refer to dermatology. Prescribe a 2-week course of a moderately potent topical corticosteroid. Prescribe a 2-week course of a potent topical corticosteroid. Prescribe a 6-week course of an oral limecycline.
Limicycline, right. Okay. Okay, good. So the answer here is, it's very obvious that the patient is having perioral dermatitis. You see the next picture. You see the entire perioral region, which is sparing the lip margins, small, pustules. I told you, pus-filled areas and small vesicles. That is the water-filled sac around your entire oral region is called as perioral dermatitis. And what is the most common cause of perioral dermatitis is usage of these unwanted creams and makeups and foundations and using steroids. When you are when you don't know what kind of steroids you need to use for your face, you're going to have a disastrous problem just like this perioral dermatitis. So the patient can actually, so basically it is a type of acne going towards the acne, but not the real acne, only in the perioral area. So this is a bacterial infection where if it is mild, if it is very mild, you can actually use certain antibiotic creams like, topical metronidazole or topical clindamycin. Now, this patient has actually a lot of papules, small raised, lesions, vesicles, pustules, so many problems. So that goes under not mild, not moderate. It goes under severe, kind of a moderate to severe lesion where you can't use any topical. You have to use oral limicycline. That is what is given. So here the other options like corticosteroids are not given because when you give steroids, you're going to create a disaster, right? Someone can read this as well, please, quickly.
21-year-old woman presents with multiple facial papules and pustules, primarily on her cheeks and chin. She has mild scarring on her face from previous outbreaks and also reports pustules on her upper back. She takes no medication and does not plan to start a family in the near future. Despite using over-the-counter face washes, her acne has not improved and she has not received any prescription treatment so far. What is the most appropriate initial treatment for this patient?
Right, good. So now you know that this case is we are talking about acne vulgaris, that is the pimples, the acne. So whenever you get a patient with acne, always try to differentiate between mild, moderate, and severe acne. These three things, because all your treatment management depends on is it mild, is it moderate, or severe acne, right? And one more other thing is, so I told you that is one thing. So can we now just slowly shift to this area? Now you see number one, what happens? I told you mild acne is this number 1 and 2. What is number 1? Blackheads. What do you mean by blackheads? Okay. You know that acne vulgaris is something that is caused, a disorder that is seen in adolescents. Mainly you see face, neck, upper trunk, chest, all these areas due to the obstruction. That means this inside your face or whatever, this small pilosebaceous follicles are there between your, the sweat glands. What happens is this keratin plugs goes and obstructs and it becomes infected. So I don't want to go more on pathophysiology. I'm just going on only the MCQ points, right? So, like I told you, mild, moderate, severe. What is mild? When it becomes infected, the upper portion, right? The upper portion, it slowly opens up. It slowly opens up. This skin, it opens up. When it opens, you see these black heads. What do you call as black heads? Whatever the contents inside the hole, when it opens up, when it is exposed to the outer environment, the oxidation process happens and it becomes black. That is what you call as blackheads. And then when that blackheads closes entirely without opening, you see something called whiteheads. So that is the difference between whitehead and blackheads. If you see both of these are actually called as comedones. This is mild acne. When you talk about moderate acne, when do you say? Now you see number 4 and 5. That means you see small papules. I told you small raised ones, small 0.5 centimeters. If it is more than 0.5 centimeters, you call it as a nodule. So when it is a papule, and if it becomes small pustules, papule pustules, it becomes moderate acne. Moderate acne. And then, just give me a minute. I'll drink some water. Sorry, I have a bad laryngitis. Sorry. Yeah. So, whiteheads and blackheads, mild. Moderate is papules and pustules. And when it becomes very severe, can you see this number F? You see scars around, right? When you get a lot of scars with this acne, and it becomes very big nodules, big, huge papules are called nodules. Then it becomes severe acne. Very important. Acne is a very important topic, right? What are the management that you can give? When it becomes a mild to moderate, that is a mild acne, you can start with 3 topical. You don't give oral. You always start with topical, and the formula is basically AB, TC, and BC. What is A and B? AB is basically you give a topical application of adapalene and benzoyl peroxide. They are not antibiotics, right? Adapalene is a type of a retinoid which should be avoided in pregnancy. MCQ, okay? Retinoids avoided in pregnancy. Then second is AB, right? A is adapalene and benzyl peroxide. You give this combination for 12 weeks and you wait and see. It doesn't work, then you go to the second line, which is called as TC. T is what? Topical tretinoin, that is also a retinoid, with topical clindamycin, which is an antibiotic. So it is AB or TC or BC. BC is what? Benzyl peroxide, and you give clindamycin. These are the combination. You balance between these. So you never give oral and you never ever give, single. Only drug that can be single monotherapy used is topical benzyl peroxide. Others are all given in combination to avoid antibiotic resistance, right? Now let's go to the moderate acne. Now mild, it's AB, TC, BC, and then you go with the moderate acne. Here, what you can use is just like that AB, adapalene, benzyl peroxide, plus you add doxycycline or limicycline. Okay, so both, this is the combination. Doxy or limicycline is the combination. Here, you have seen a lot of people, like even we, initially what we used to give is we gave clindamycin, local application, and then we give oral. But the nice guidelines tell you never ever give both combination, a topical antibiotic and an oral antibiotic is not given. Very important MCQ, right? Then when it becomes a severe acne, you have to refer to a dermatologist for the need of isoretinoin, that is retinoids, which you cannot give as a family physician, only a dermatologist has to give, right? Next, let's talk about the tetracyclines, that is the doxycycline that we give. You know that you cannot give in pregnancy and breastfeeding. It's an MCQ. And also, if the child is less than 12 years, you don't give. In that case, you can actually give erythromycin, which is very, very safe, right? One thing. Other thing is, like I told you, you don't combine both a topical or an oral antibiotic because you can get antibiotic resistance. After you combine all these things, let's say it doesn't get better at all, then you can actually go with a combined OCPs, right? OCPs, that is very, very helpful because it is having anti-androgen properties. Very, very important, and should be given only for 3 months. It's a MCQ. 3 months only it is given. Then when you're thinking of referring the patient to a specialist for oral retinoids for a severe form of acne, that's when you refer the patient, right? Right. So I just told you the what are the nice guidelines. The criteria to refer is if the patient has a very severe acne, nodules, scarring, and huge cysts, you refer, right? That's about it. Okay. Can someone tell me, just read this question, it's a very small question. Quickly, please don't waste time. Quickly, just read only the line.
Which one of the following steroid creams is the most potent?
Yeah, just don't read the company, just read the ones, the generic ones, the fluticasone.
Fluticasone propionate, clobetasone butyrate, betamethasone valerate, betamethasone valerate, percent 0.1%.
Right.
Clobetasole propionate 0.05%.
Right. So actually, even when I was a student learning all these things, I was very confused on what are the steroid, what is heavily potent, what is mild. I'm also confused. So we have to know there are 4 categories of steroids: very, very mild, and then kind of a potent, mildly potent, and very, very the most potent. These are the 4 groups, and sorry, all your management depends on that. What is a mild form? Mild form is hydrocortisone 0.5% to 2.5%. Very, very important. Why I'm talking about mild is the mild one is the only one that you can use on your face and your flexures in the body, your axilla, groin, all these things you can use only mild one. And recently the study has proved that using mometasone is even not recommended on the face. You have to use only the mild one, which is hydrocortisone 0.5 to 2.5%. Then coming back to the potent, that is mild potent, moderate potent, severe potent. Mild potent is betamethasone valerate. You see the option C, that is 0.025%, and clobetasone butyrate, that is 0.05%. You see option B and C. Both of them come into mild potent. When it goes into a moderately potent one, then betamethasone valerate, which is in your option D, betamethasone valerate 0.1% goes into moderate potent. So again, betamethasone valerate 0.025 goes into mild, and betamethasone valerate 0.1 goes into moderate, and the maximum potent one is clobetasol propionate, which is the last option, option E, that is 0.05. Why I mentioned about this maximum potent? Because the severe most potent one is the only one that you can use in your scalp, palms, and soles. Rest all the things you can use in your body. And hydrocortisone, the mild one, is used on the face. So very, very important MCQ. I just told you mild, moderate, mild, moderate, mild potent, moderate potent, severe potent. Severe potent is clobetasol propionate, option E. Right. Right. Can someone please, read this, please? Just read quickly. We'll try to finish as much as.
41-year-old man
Yeah, good.
presents with an itchy rash over his arms and abdomen. It
Mhm.
has got gradually worse over the past 3 days. What is the most likely diagnosis?
Right.
Scabies, pityriasis propria, erythema multiforme, urticaria, guttate psoriasis.
Right. Okay, good. So, yeah. So this condition is actually, you see, it's kind of a, like a, let's say it's a kind of a papule, and it has actually there is a few small vesicle as well, and it has burst, and you can see like small pigmentation as well. So this one severely itchy for the last 3 days, all of a sudden it came, the diagnosis most likely goes into scabies, right? And sorry, yeah, okay, scabies. And about scabies, when we talk about it, it's very, very important. MCQs only I'm going to talk about. So scabies is caused by a mite called Sarcoptes scabii, and it happens with prolonged skin to skin contact from children or affected young adults. It comes together. What happens is, I just taught you the layers of the skin, right? CLGSB. C is stratum corneum, and that layer, the stratum, the stratum corneum, is where the scabies mite, each mite lays its eggs. It lays its eggs, and it causes something called a type 4 hypersensitivity. It's an MCQ. So scabies lays the eggs, causes type 4 hypersensitivity. After 30 days, after 1 month, they hatch. Those small eggs start hatching. It causes very, very severe, widespread pruritus all over your body, starting with the fingers, interdigital spaces, and flexor aspect of your wrist and ankle. And trust me, even the scalp, face, everything can be affected. And the treatment that you can give, the first line is permethrin 5%, and you can give malathion as well, which is 0.5%. These two are very, very important, and the first line and the second line. And you need to give certain advices to the patient. If the patient is going to use permethrin, it should be put to the entire body. Don't forget MCQ, scalp, face, entire body, left it for 12 hours, and then you wash. If you're using a malathion, you need to use for 24 hours. That is malathion 0.5%. Okay. Next, you need to tell, if you're treating one family member, this man, if we are treating, we need to treat all the close contacts in the body, even if the patient is asymptomatic. And laundry, iron, clothings, all the clothings and the bed, towels, etc., everything. All right? Right. So you know that we first use the treatment stat, 12 hours for permethrin, 24 hours for malathion, entire body, wash it off, repeat this again in 7 days, because the itching can continue even up to 15 days. Don't worry. Tell the patient, you will have itch for next 2 weeks, but just don't worry. All right? Okay. This is about scabies. Everything I told is just MCQ. You don't have to read anything extra. Okay. Can someone quickly read this, please? Quickly. Don't waste time. Just reading only, please.
23-year
Okay, good. Yeah. Anyone? Yeah.
a 23-year-old woman who is 10 weeks pregnant, present with a rapidly growing lesion on her finger. This has grown from the size of a pink prick when it first appeared 4 weeks ago. What is the most likely diagnosis? Viral wart of pyogenic granuloma, capillary hemangioma, squamous cell carcinoma.
Right. Okay. So here, if you see, it's actually after a pin prick, and the most important one in the question is pregnant. Pregnant, a pin prick, suddenly raised lesion, a huge kind of a nodule is actually, you call this as a pyogenic granuloma. So what about the other options? Why couldn't be the other options? I'll just show you some pictures. Right. You see this number one, viral wart. Viral wart is actually, you see in the hands, which can be, a dome shaped. What is a dome shape? The shape of, Taj Mahal. You see the top part like this? that is called the dome shape. So this is a dome shape. And there are so many types of viral warts. It can be finger projections, it can be pricky, or it can just be a dome shape. These are viral warts. And as you know, it is caused by human papilloma virus. And you know that 6, 8, 18, 11, etc., etc. And the ones like 16 and 18 are, the ones which can cause all the CA and all those things. So viral warts, you need to treat with cryotherapy, where you actually send this, nitrous oxide gas from far. That is one option. Or using 17% of salicylic acid on this lesion. These are the two best options that you can use. And if you get a genital wart, the treatment, all these MCQs, what are the treatment options available? You give something called podoxyphylline. Podoxyphylline is the treatment that this thing it in viral wart. And what is OFF? OFF is basically a kind of a viral pox virus in patients who are handling this sheep, cattle. Those people can have a small pus-filled, a vesicle, like kind of a pus-filled, either a pustule or a vesicle which is a water-filled. So this patient is not having this. See, this is not that. And then capillary hemangioma. Capillary hemangioma is a superficial hemangioma seen in children, right? As soon as they are born, they get this lobulated, multi-lobulated in the face, in the head, in the body. It can even be, you can even have this in your respiratory system as well. So it is very, very benign. When the baby turns 10 years, 95% of the times it disappears. You don't have to do anything unless this capillary hemangioma can grow so big and it can obstruct the visual field, or if it is inside your respiratory tract, you cannot breathe. If these two severe side effects are there, then you need to manage, or else capillary hemangioma can be left alone. Next, squamous cell carcinoma. I will explain that to you later. So squamous cell carcinoma, most of the sun exposed areas, face, hands, and your feet, okay, with a very severe ulcerated lesion. Please biopsy the lesion. Then you get you get an answer from that. So we studied the pyogenic granuloma. Now, can we talk about pyogenic granuloma now? So pyogenic granuloma, there are only 3 factors that can cause either trauma or either trauma or pregnancy. And it is most common in women and young adults. And the sites that you can see, like you see the fingers, upper trunk, head, and hands, very common in pregnancy. Initially, how does it start? A very small brown red spot, which slowly becomes raised like this, like I said, a dome shape. And it is so very rich in blood vessels, and you can have severe bleeding if it is ruptured. So if it is occurring in pregnancy, now this question, if they have asked the treatment, I will tell no treatment because it will resolve postpartum, right? And if you get this in any other age group, you just have to remove it by cauterizing it, using some electricity and cauterizing the current, or else you use, like I said, this cryotherapy, the gas, the nitrous oxide, what I said, we just send the gas inside, or else there is something called curettage. So curettage, cryotherapy, cauterization. Triple C. Most of your skin conditions, this triple C is the management. What do you mean by curettage? Curettage is, it's like this. A small blade which is whole. It is a round in shape, where you keep it in your lesion, scrape it. That is called curettage. Right. Next. Can someone quickly read this, please? Quickly read this, yeah.
A 26-year-old man who is HIV positive is noted to have developed seborrheic dermatitis. Which of the following 2 complications are most associated with this condition?
Right.
Alopecia and otitis externa, blepharitis and otitis externa, photosensitivity and alopecia, photosensitivity and blepharitis, blepharitis and alopecia.
Right. So this condition, if you see, he has this problem right near his ears, and I told you eyebrows and the ears. So it can affect somewhere the eyes and your ears. So this condition, which is called as seborrheic dermatitis. So the answer here is blepharitis. That is, this since your eyebrows are affected, slowly it can spread to your eye, the lid margins, and that inflammation of the lid margin is called as blepharitis. And infection of your external auditory canal is called as otitis externa. So this is your seborrheic dermatitis. So quickly about seborrheic dermatitis, like I said, it is actually inflammation in all the areas I told you, which is mainly caused by a fungus called Malassezia furfur. Just keep it in your mind, and when you get an MCQ, just try to put it. It's Malassezia furfur. I told you the areas where it can affect. It is very, very common in two people, that is HIV and Parkinson's. And what is the treatment? The first line treatment is ketoconazole 2% shampoo in your head, scalp. The second option is, this Head and Shoulders, right? They have a small chemical called zinc pyrathione. That is the second option. Number 3 is tar, coal tar shampoo, and number 4 is selenium sulfide, the company which we use, Selsun. These 4. Number 1, starting with the first line, is ketoconazole shampoo, zinc pyrathione in your Head and Shoulders. Number 3 is coal tar, and number 4 is selenium sulfide. This is the treatment for the entire scalp psoriasis. Sorry, the scalp seborrheic dermatitis. Right. Can someone quickly go ahead with this, please? I think I just told you. Anybody, please just read it, please. Quickly, I want to just finish it as much as we can. Please, yeah.
37-year-old complains of flaky eyebrows, which underlying condition is the skin condition most associated with diabetes mellitus, alcohol excess, sarcoidosis, tuberculosis, HIV.
Right. I just told you now, it's seborrheic dermatitis, and it is common in two people, that is Parkinson's and HIV, right? So that is the answer, right? So these are the seborrheic dermatitis, the areas we can affect. I just showed you all the flexures, scalp, the nasolabial fold, eyebrows, behind the ears, all the areas where is sebum rage. Okay. Can someone quickly read this, please? Just read it, please. Just reading only.
Dermatological investigations,
Okay,
punch
good.
biopsy, skin scraping, clinical diagnosis, no investigation necessary, bacterial swab, viral swab, incisional biopsy, excisional biopsy, shave biopsy, blood test for anti-nuclear antibody. For the following dermatological condition, choose the most appropriate investigation option.
Okay, I'll quickly go through what are these biopsies. What is punch biopsy? Is basically, it's like a pen. You have a pen. Let's say that you take the inside part of the pen, right? Whatever the ink is there, you throw it away. And what happens? The pen, it has a hole, right? You just punch it, and once you put it like this, once you rotate it on your hand, you get an impression, right? That is called the punch. So instead of that hole, they actually put a round blade inside. So you put it, and you rotate like this, rotate like a pen, and you get a hole, a round chunk coming out. That is your punch biopsy. And your skin scraping is nothing but you use a blade and scrape the skin. Check it under the microscope. That is skin scraping. Bacterial swabs, taking a swab for bacteria, virus, What is an incisional biopsy? Excisional biopsy, I told you, when you get a lesion, you take the entire lesion, you cut open from side, oval shaped, and entirely you take it. That is excisional biopsy. What is incisional biopsy? You put a hole, you put an incision inside and take a small piece with the border. That is incisional biopsy. And what do you mean by shave biopsy? The blade, you have a blade, you bend the blade like this, right? Into this shape, like this, right? And you hold it in both the sides, and you go like this, shave the skin with the blade is called your shave biopsy, right? And the same person who read, can you please read the question, please? This one quickly. A 43-year-old woman.
43-year-old woman presents with non-scaly erythematous plaques and papules in the malar distribution. These lesions also affecting the chin and nasolabial folds. She notes that these symptoms worsen after exercise and alcohol intake. She has no other symptoms of note and has no significant medical history or medications.
Right. So, yeah, okay. Can you go to the next one also? Yeah.
Okay. A 55-year-old man presents with a new pigmented lesion on his stomach, which appeared in the past month. This is unlike his other pigmented lesions. This is 6 millimeter in size, has an irregular border, and also has some background erythema. He has no family or personal history of skin cancer.
Okay, thank you. Stop. So, number 14, we were discussing. So, you told me, thank you very much for reading. You were telling me there are some plaques, papules in everywhere, nasolabial fold, chin, all these things, and it becomes very bad with alcohol intake and exercise, right? So, there's another entity that we discuss, acne vulgaris, we discuss everything. So, this doesn't look like SLE, right? Because nasolabial is affected and the nasal bridge is also affected in SLE, which is not the case here. And the chin is also affected in this question number 14, but in SLE, it is not affected. So this is called acne rosacea. Acne rosacea. That is a kind of a severe form of acne. I'll just show you. So this, the option is this actually. They're asking options from here. And since it is a clinical diagnosis, I mean, we don't do any investigation. And question number 15 is basically, it's a new pigment lesion. So I just told you anything that is new, a blackish lesion, always suspect that it could be a melanoma and do a excisional biopsy. Remove the entire thing. If you start doing a shave biopsy or a punch biopsy, you might miss the important affected area. So do a excision biopsy. Can you please read the 16 also, please? Question 16.
Okay, sir. 25-year-old man presents with multiple pruritic lesions on his torso that started 1 week ago. He tried hydrocortisone 1% cream for 3 days with no improvement. On examination, there are 4 well-circumscribed annular erythematous plaques with an advancing scaly border and central clearing.
Right. Okay. Thank you. So here now, among the options, now when I just told you, I used the word central clearing with a scaly border. So this is very likely to be a tinea infection. So it's a tinea corporis, which is there, patient is having this condition in the torso and started 1 week ago. So here, like I told you, if it is a nail infection, we take the nail clipping for treatment. But when you get a tinea in your body, you do not do any investigations. Straight away, you start management. So this is a clinical diagnosis, right? See, the first one is a clinical diagnosis we just mentioned, that is acne rosacea. Then it's a melanoma where you entirely remove that. You don't do any kind of biopsy, remove that completely. And then number 16 is a tinea fungal infection. It is a clinical diagnosis, no investigations, right? So we were discussing about acne rosacea. It's very, very important. So acne rosacea is something just like this. I mean, I'll just show you a picture, but I'll just discuss a bit quickly. So it typically affects the entire face. When you get a person who is the entire face, that is the nose, cheek, forehead, everything is red in color. It starts, that is called as flushing. So someone coming with flushing and then dilated small vessels, that is called as telangiectasia, flushing, and then later it slowly goes into papules, pustules, and then you would have seen some people's nose. I'll show you a picture. It's so big. That's called rhinophyma. That is it's a severe form of acne rosacea. All this put together is called as acne rosacea. I'll discuss about the treatment quickly. Can someone read this, please? Yeah. This is the one I was discussing about. Okay, quickly, please. We'll try to finish as much as we can. Quickly.
A 54-year-old man is referred by his GP to the dermatology outpatient department due to a facial rash which has persisted for the past 12 months. On examination, there is a symmetrical rash consisting of extensive pustules and papules which affects his nose, cheeks, and forehead. What is the most appropriate treatment? topical metronidazole, oral isotretinoin, oral doxycycline and topical ivermectin, oral hydrochloroquine, oral prednisolone.
Right. So I just told you that we just discussed about acne rosacea. It can affect the nose, cheeks, chin, everywhere. First, it becomes so red. That is called flushing. So number one is topical metronidazole. So previously, according to NICE guidelines, topical metronidazole was the first line for acne rosacea. Not anymore. Right? I'll tell you why. Next, oral isotretinoin. No, we give that only for severe acne, not for this. Then coming back to number 4. Option number 4, oral hydroxychloroquine, which is given in case of SLE or joint, autoimmune related joint problems. So this is also not the case. And at the last, it's oral prednisolone, which is also not the case. But here the treatment is oral doxy and topical ivermectin because the patient is having a moderate acne rosacea. Like I told, everything, even acne vulgaris, that is the pimples, or even acne rosacea, all these things, please divide it into mild, moderate, and severe. So then again, in this, I told you about everything, telangiectasia and flushing. Later on, it goes into papules, pustules, that is the moderate, and severe. You see this nose, bulbous, huge enlargement of the nose is rhinophyma, right? And when you get the mild, that is the red or redness of your face, the best drug that you can give is a topical brimonidine. Brimonidine is something that actually causes a vasoconstriction, right? Brimonidine, vasoconstriction, and it starts working. It reaches its peak. It reaches its peak in 30 minutes, gets the entire face better to your normal color, and then comes down in 3 to 6 hours, right? MCQ. Suppose if it is a moderate, like this patient is having moderate. So, sorry, not moderate actually. Why I wanted to say it's not moderated? Because pustules, papules, and so many things are there. So it goes into severe. So mild, I spoke to you, brimonidine. If it is moderate, you use only topical ivermectin only. Then when it becomes a severe form, you give a combination of a topical ivermectin plus oral doxycycline, which is the answer in this case. So you refer acne rosacea, not just like that, only if the patient is having this nose, rhinophyma, huge nose, you refer, or else not getting better with your treatment, even giving one oral doxy and topical ivermectin, not getting better, refer the patient. Yeah. So can we go to the next one, please, quickly, somebody?
Lesion below started as a small red papule which grew in size before starting to ulcerate. Which one of the following conditions is most associated with this skin condition?
Right.
Rheumatoid arthritis, sarcoidosis, primary herpes simplex virus infection, TB, thyrotoxicosis.
Right. So you have to know one thing. So there now this skin lesion, when you see, it is actually it's what they told is this patient said that it started with a small red papule, then slowly growing into size. When you see this lesion, we can see it has gone a bit deeper, and it is kind of a necrotic ulcers with the borders being violet. That is called as violaceous border, deep necrotic ulcer, which has started from a small red papule, is called as pyoderma gangrenosum, right? So this is pyoderma gangrenosum, which is 50% of the times idiopathic. You don't have a cause. Remaining causes are basically inflammatory bowel disease, like Crohn's or ulcerative colitis. Number 2 is connective tissue disorders. That is the most important that you can say is the rheumatoid arthritis. And then number 3rd cause is myeloproliferative disorders, right? This is the major cause. And if you see why they have mentioned thyrotoxicosis is, that is also another reason you can get leg shin lesions, which is called as pretibial myxedema. So pretibial myxedema will not be unilateral. It is symmetrically bilateral usually seen in Graves' disease. So how do you basically get it? I'll just show you. Okay, I'll show you a picture in the future slides. So it is shiny color, shiny. And once you peel off your orange, you peel the orange, the inner side, that is how it is. Orange, red, shiny peel, which is called as your thyrotoxicosis. Tuberculosis also can get an ulcer, but not very faster like this. Because this case, it quickly started from a small red papule, but tuberculosis, it would have been much worse. And the other one, why they mentioned number 3 is primary herpes simplex, is because another lesion that herpes simplex can cause is called erythema multiforme. I will show you a picture. What do you mean by erythema multiforme? You get a huge, have you seen target sign, a round and another round in the middle. See, people, they do this archery where they send this bow and arrow. So you see a round and a small target. So that is called a target sign, which you see in erythema multiforme, which is seen in primary herpes simplex. And sarcoidosis will not cause this thing, but it can cause another one. Just keep it in mind, very, very important. It is called erythema nodosum. I will show you in the next slide, the pictures. Yeah. Can someone quickly read about this, please? Please don't waste time. Quickly. We'll try to finish as much as we can. Quickly.
Section 19.
This question is so important because it came from my DFM and it came from my MD also. Huh? So please read this. Yeah, go ahead. Read this, please. Yeah.
When we note and presents skin changes on his neck, which he is self-conscious. He denies any other symptoms and feels well in himself. On examination, you note some areas of darkening and thickened skin in axillary creases. His blood pressure is normal and BMI is 38. What is most likely diagnosis?
So they're talking about Addison's, vitiligo, candida, acanthosis nigricans, and pityriasis versicolor. So this is very, very clear-cut diagnosis of acanthosis nigricans. What is it basically? So when a patient is obese and diabetes, or all those things, what happens with your insulin? There is insulin, but your insulin is resistant. You resistant to your glucose. So the insulin, actually the production is more. So insulin resistance, hyperinsulinemia, and that goes and stimulates your keratinocytes in your skin. So hyperinsulinemia, keratinocytes, it stimulates and it causes this velvety brown patches like thing, which is called as acanthosis nigricans. And I got an MCQ for my exam, DFM, as to what are the causes. I'll tell you around 7 to 8 causes. Very, very important. You have to memorize these 8 causes. Number 1, you get it in type 2 diabetes. I just told you why. And obesity, polycystic ovarian disease, acromegaly, Cushing's syndrome, hypothyroidism, familial, and drugs. 2 drugs called combined OCPs and nicotinic acid, right? But one important thing I missed is very, 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 very important is if you get this acanthosis nigricans in unusual places, let's say inside your oral mouth and everywhere in your body, you have to suspect GICA, gastrointestinal carcinoma. So don't forget, very, very important. All right. Okay. And then, so why isn't this, now they were discussing about vitiligo, candida, pityriasis versicolor as well. So what is vitiligo? Vitiligo is basically an autoimmune condition you see in this number 1. And it is mainly, a lesion when there is normally in our skin, we call it as a normally pigmented. This acanthosis nigricans you see in picture number 3, it is hyperpigmented, right? Hyperpigmented. And number 4, you see the color is a bit low. It has come down. So you call this as a hypopigmented. But vitiligo, there is no pigment at all, right? So you tell this as a depigmented lesion. So depigmented lesion like this whitish patches we call as vitiligo, and the treatment that you can give for vitiligo is starting from hydrocortisone cream or else you can give immunosuppressants like tacrolimus cream, or else you give a short course of oral dexamethasone for a week or two. This is the treatment for vitiligo, right? So shall we go to the next one, please? Can someone, this is an easy one we just discussed.
62-year-old female is referred to dermatology by her GP due to a lesion over the skin. It initially started as a small red papule, which later became a deep red necrotic ulcer with a violaceous border. What is the likely diagnosis?
Since I discussed, you can answer this, yeah. Yeah.
Answers are necrobiosis lipidica diabeticorum, syphilis, erythema nodosum, peritibial myxedema, pyoderma gangrenosum.
Right. The answer here is I just discussed just now, started with a red color small dot, became a necrotic ulcer with the entire borders become violet and violaceous. So this is pyoderma gangrenosum. I discussed the reasons as well. And you see this pretibial myxedema, I just told you, shiny orange peel of the skin seen in Graves' disease. And number 3, I told you erythema nodosum. We just saw previously, sarcoidosis had it. And there's an easy way to remember erythema nodosum. There are 4 S's. What are the S? Streptococcal infections, sarcoidosis, drugs like sulfonamides, and the 4th S is actually inflammatory bowel disease. You don't have S, but you have to just remember inflammatory bowel disease, sulfonamides, streptococcal infections, sarcoidosis, you get erythema nodosum. So what are these red small bulgy? What are those? They are basically tender inflammation of the subcutaneous fat, symmetrically seen. That is called erythema nodosum, which is seen in the shin. There's another condition you see, number 1, necrobiosis lipidica diabeticorum. What is that? That is basically yellowish. You see a bit yellow color, right? Yellowish, pale colors seen in the shin of diabetic. And also, if you could see picture number 1, right in the middle, you can see something like a dilated blood vessels, which is called telangiectasia. So you learn 2 telangiectasia, one in acne rosacea, and next is necrobiosis lipidica diabeticorum. All these are very, very important MCQs. Can quickly somebody read this, please? Quickly, somebody, please. Even a person who has read it, it's okay. Go ahead. Yeah.
57-year-old patient noticed a patch on her face for a couple of years and it is very slowly enlarging. It doesn't cause him any symptoms. He tells you he has worked as a builder, then a property developer, so has had lots of sun exposure over the years. On examination, there's a very slightly raised, rolled, pearly edge and a tiny eroded area in the center. There is no surrounding inflammation and it doesn't feel indurated. What is your management plan? No action needed because low risk lesion. Prescribe a course of 5-fluorouracil, routine referral to dermatology, 2 weeks wait referral to dermatology, 2 weeks wait referral to oncology.
Right. So this case is a very, very clear cut of basal cell carcinoma, right? Okay. So the answer I would like to go here is the option C, which is a routine referral to dermatology. Why? The reason why is basically you see basal cell carcinoma is something that is the very, very safest kind of carcinoma that you can get on the skin, right? And it is also called as a rodent ulcer. Why is it called rodent ulcer? Is it doesn't spread. There is no any, I mean, metastasis is very, very extremely rare, but it just goes down and tries to burrow itself underneath, locally invasive. That is why it's called as a rodent ulcer. And it is the most common type of cancer in the Western world. But here also you see in Sri Lanka, we see as well. There are many, many types. You see this nodular, superficial, pigmented, morphic, basosquamous, many, many causes. But MCQ, the commonest one is nodular basal cell carcinoma, number 1. So sun-exposed areas in the face. And initially it starts with, you see the number 1. Initially it starts with a pearly kind of a pearl, white pearl kind of this thing. It becomes a small papule, and then it starts to ulcerate in the middle. See, in the middle. And also, if you could nicely see if you go to your screen and see here also, you see telangiectasia. Telangiectasia is small dilated vessels. So telangiectasia, we read it in this, and diabetic aurum as well, and the necrobiasis diabetic aurum and acne rosacea, three things, right? And then how do you actually manage this? If you suspect this, since there is no any metastasis, do not be in a hurry. Go for MCQ. Routine referral should be made. No urgency, no urgent. Just routinely refer. Here also, I just told you, any skin conditions, the three things come into play. Curettage, that means take a round spoon and, remove it like this, kurala ganna kya, like that. That is called as a curettage. Cryotherapy, I told you, your gas, nitrous oxide, and then you can actually use cryotherapy, curettage, and also cauterization can be done and surgically remove. These are the options, which is not very urgent, right? Can anyone quickly tell me this, please? Quickly read, please. Yeah, quick. Someone who has read also, no problem. Just read it. It will be very easy for you later on. That's why. Please go ahead. Yeah.
A father attends your surgery regarding his 4-month-old baby son's birthmark. There is a small vascular plaque on the scalp which doesn't seem to be bothering the baby. You diagnose a strawberry nevus. What is the most appropriate first-line management? Tropical steroid, laser therapy, watch and wait, biopsy, curate. Cautery.
So I just told you, strawberry nevus is not going to do anything. It's a capillary hemangioma, very superficial, and it develops slowly at the first month. Infant, first month of life, slowly increases in size, slowly increase by 6 to 9 months increases, and by 10 years, 95% of the people, it completely resolves. And only complications, like I told you, if it is actually somewhere in the temple, it can obstruct the visual pathway. If it is in the respiratory system, it can cause difficulty breathing, and then it can ulcerate and bleed. These are the only things. And strawberry nevus, no treatment, wait and watch. That is the answer here. It will just get better if the patient is having problems, like I told you, obstructing the visual field, causing difficulty breathing. If it is inside the respiratory system, then you actually give propranolol beta blocker, either orally, okay? Orally, there are syrups made, or else you can use topical timolol. Those things can be used if it is bothersome only, or else wait and watch. Right. Can somebody quickly tell about this, please? Yeah. Just read quickly.
An elderly man develops a generalized pruritic rash. Which one of the following is mainstay of treatment? Gluten-free diet, phototherapy, oral corticosteroids, long-term oral antibiotics, potent topical corticosteroids.
Right. Okay, good. So you see, what do you see this? I just told you, if there is water-filled sac, which is less than, 0.5 centimeters, very small one, like you can even say it 1 centimeters, it is called vesicle, and a larger vesicle, water-filled sac more than 1 centimeter, you call it as a bulle or a bulla, whatever, right? So this condition, if you see from far, most of the bulla are so tense. Why I said it's tense is, for at least your exam point of view, there are only two conditions that you should remember. One is something called bullous fembigoid, and then other one is fembigus vulgaris. These two conditions are very, very important if you're thinking about the bullous conditions. So how do you differentiate between the two? Now, I was telling you the layers of your skin, right? C, L, G, S, and B. So very, very superficially, if the bulle comes out, it can rupture very easily. So very superficial, already ruptured, goes towards fembigus vulgaris. something very, very tense like this, cannot even break it. It comes from the deeper, that is the dermo-epidermal junction. It comes from the dermo-epidermal junction. It is so tense, you can't break it. It is called bullous pemphigoid, which is in this patient. So the answer here would be no long-term antibiotics. No. Why? Because this is an autoimmune condition, which is basically a blistering condition that produces antibodies which destroys the proteins, right? Destroys the proteins in the dermo-epidermal junction. It is so tense, and you don't get any other lesion in the mucosa. One more differential diagnosis between this and pemphigus vulgaris. I just told you, this one, there is no oral lesions, but pemphigus vulgaris, you have oral lesions. That is one more important, MCQ point, right? Other thing is, how do you diagnose this? You take a small skin biopsy and you check it with immunofluorescence. Immunofluorescence, it can actually show IgG, and C, complement level, C3 at the dermo-epidermal junction, because that is where it is arising from. And then how do you treat? Directly refer to the dermatologist. Oral corticosteroids are the mainstay treatment. So now you learn two conditions. These two are the ones which you can get in exam, right? Okay. See the first picture, how tense bulle. Can you see the second picture? There is only one area which is filled with pus. All the areas have broken down. That is called pemphigus vulgaris. See, this is tense, which is coming from the dermo-epidermal junction, and the second one is pemphigus vulgaris, coming a bit upper layer. It is breakable easily, and pemphigus vulgaris, you get oral lesions, and bullous pemphigoids, no oral lesions. Right. Okay. So I just told you about this. Right. Anything I missed? Pemphigus vulgaris, I told it's an autoimmune condition, and you see the features. Oral involvement, I told you 50 to 70% of the patients have oral involvement, and the blisters are so flaccid, it can break off easily. And there is something called Nikolsky sign. What is Nikolsky sign? If the bulla is here and you use your thumb and just push it like this, mild pressure, it can break off. That is called Nikolsky sign, right? Okay. Can someone quickly read about this? I think we did it. I will not waste time anymore. This is then again, it is a bullous pemphigoid, and we give oral corticosteroids, right? Can someone read this quickly? We'll try to finish as much as we can. Quick.
A 33-year-old woman asks you to look at a spot on her arm that has been present for several months. It has not changed recently and is completely asymptomatic. What is the most likely diagnosis? Leiomyoma, basal cell carcinoma, amelanotic malignant melanoma, dermatofibroma, nodular prurigo.
Right. So this cannot be leiomyoma because of the smooth muscle involvement. This is anyway a lesion. And basal cell carcinoma, we just saw, it is a pearly white with a central ulcerated like thing. This is not the issue. And melanoma is not the thing because the color itself doesn't show anything like that. So it could be either dermatofibroma or nodular prurigo. Let's see the next picture. This is actually dermatofibroma. I'll show you the pictures here, right? So you see basal cell carcinoma, you just know now, outside it is rolled, inside it is ulcerated. So this is not the one. And I told you the malignant melanoma, the blackish brown color, no. And nodular, what is nodular prurigo? Nodular prurigo is also a kind of autoimmune condition. When you see the patient, multiple wounds which are broken, just like that. So this is not the case. So this is basically dermatofibroma. What is dermatofibroma? So it is basically a benign fibrous, whatever the fibers in your skin, fibrous benign skin lesion coming from your skin, and it is an abnormal growth of dendritic histiocyte cells. This is an MCQ, dendritic histiocyte cells. Very, very commonly, it is precipitated by injury. After injury only it can occur, usually on the arms and your legs. Starts with a small papule, then becomes a nodule. It is only 5 to 10 millimeter in size. Very important MCQ, right? Okay. Can someone quickly, we did this. Can you quickly go for this, please? Read this.
31-year-old woman develops painful purple lesions on her shin. Which one of the following medications is most likely to be responsible?
Right. Okay. So I just explained to you bilateral shin tang wala there are inflammation. This is called as erythema nodosum. So I told you it is inflammation of the subcutaneous fat. It is tender erythematous lesions in the skin, and it comes because of, I told you, the streptococci SS, streptococci, sarcoidosis, inflammatory bowel disease, malignancies, and drugs like sulfonamides and combined OCPs. And one more important thing I forgot to tell you is pregnancy as well. So these are the causes. Streptococci, that is infection. Streptococci, even tuberculosis, sarcoidosis, inflammatory bowel disease, drugs like sulfonamides, OCPs, and what else? Pregnancy and malignancy. These are the causes. It comes and just goes away without any scarring. It heals. That is erythema nodosum. So the answer here is combined OCPs, not any other pills, because either combined OCPs or sulfonamides are the only cause of erythema nodosum. Right. Can you quickly read this? I think we just did this. Now we can quickly go. Quickly, somebody.
22-year-old woman presents with a one-day history of rash on her neck. She noticed it in the morning shortly after she woke up. It is associated with mild itch and burning sensation. Aside from a cold sore infection, which has been treated with over-the-counter medication, she is well in herself. There is no recent travel history or insect bites. She has no pre-existing medical conditions. On examination, the lesions were non-tender and are as shown below. Which of the following is the most likely diagnosis? Erythema migrans, necrobasis lipoidica, erythema nodosum, erythema multiforme, dermatitis herpetiformis.
Right. If you see the lesion, I just told you it's rounded in shape and the middle area is like a target, right? A target. So that is called as target sign, which is seen in erythema multiforme. So this is not erythema migrans, because erythema migrans is a different entity where we see it in Lyme disease. We don't see that much in Sri Lanka because it's only in the Western world due to ticks, where they go hunting and camping. Tick bite, you get Lyme disease, you get this erythema migrans, which is a huge sign. It's actually called as bull's eye sign. Okay, that means not a small target sign, big target sign, huge target sign. It is erythema migrans. Necrobasis lipoidica, it's not the one we just saw. Yellowish color. Telangiectasia seen in diabetics, no. Erythema nodosum, no. Bilateral symmetrical, so this is not the thing. So erythema multiforme, yes, this is the answer. And yes. So see, right. So I thought I didn't have a picture. So erythema migrans, you see a bigger version of the target sign. Smaller target sign is erythema multiforme. Let's quickly talk about erythema multiforme. What is erythema multiforme? So after you have certain medications or after certain infections, you get these target signs, which is called as erythema multiforme. And if that erythema multiforme goes into a severe form, where you get oral lesions, you get all the skin peeling off, that is called as erythema multiforme major, which is also, or previously it was called Stevens-Johnson syndrome, right? So what are the causes of erythema multiforme? Very, very important MCQ. What are the causes? The most important cause is herpes simplex virus. That is the most common cause. Second most common cause is idiopathic. That is the second most common cause. Third cause is due to bacteria, that is Mycoplasma and Streptococcus. These are the third one. And the fourth important cause for erythema multiforme, that the target lesion, is drugs like penicillin, NSAIDs, oral contraceptives. These are three things. And then again, here also, just like your erythema nodosum, sarcoidosis, malignancy, you can get erythema multiforme. But you have to remember the most important thing is herpes simplex and idiopathic are the commonest cause, and Mycoplasma, Streptococcus. If you remember these things, that's more than enough. So it can be occurring in mostly upper limbs, and very, very minor itching, not major itching. So pruritus is minor. Upper limbs are more commonly affected than lower limbs, and target lesion, that is erythema multiforme. Can you quickly somebody read this? 67-year-old man.
A 67-year-old man who is a retired builder presents following the development of a number of red scaly lesions on his forehead. These were initially small and flat, but are now erythematous and rough to touch. What is the most likely diagnosis? Pityriasis versicolor, seborrheic keratosis, polymorphous light eruption, actinic keratosis, malignant melanoma.
Right. So let's go with the options here. So what is pityriasis versicolor? Is this pityriasis versicolor? No. Pityriasis versicolor is basically what we call as aluhang, where you get it in every part of the body. And like I said, just like your seborrheic dermatitis, this is also caused by the same fungus, which is called as Malassezia furfur, MCQ, Malassezia furfur. And it can occur with hypopigmented, mostly hypopigmented, like whitish patches, just like your vitiligo, but it can be brownish, hyperpigmented as well. And they are called macules. Macule is what? Smaller version of patches, not raised with the skin, right? Mostly trunks, upper extremities, etc. These are pityriasis versicolor. You see this? Pityriasis versicolor. This is not the diagnosis. So is it seborrheic keratosis? It is not seborrheic keratosis, because seborrheic keratosis is basically a brownish black plaque, raised lesion, multiple lobulated lesions on the skin, just like that. Commonly, you can get it in the face and the trunk, right? Commonly in the face and the trunk, it's very rough. You can't even remove this. So this is not the answer here. And malignant melanoma is also not the answer here. Where? Right, it's not the answer here. And what do you mean by polymorphous light eruption? So when a person walks under the sun, due to delayed hypersensitivity because of the UV radiation from the sun, delayed hypersensitivity, all the sun exposed areas, not the flexors, but the extensors under the sun, you get these small papules, itchiness, that is called as polymorphous light eruption. So what is the diagnosis here then? It is actually nothing but this actinic keratosis. What is actinic keratosis? You know, squamous cell carcinoma of the skin. But there are certain skin problems which are pre-malignant towards squamous cell carcinoma, MCQ. But what is the pre-malignant carcinomas? Actinic keratosis and Bowen's disease. These two are actually sun-exposed areas. You get small crusty, just like your impetigo you saw, crusty lesions under the sun-exposed pre-malignant is actinic keratosis, right? Okay. Can someone quickly read about this, please? Quickly, yeah. It's quite easy only. Can someone like quickly?
72-year-old man.
Go ahead. Yeah, go ahead. Yeah, please.
72-year-old man attempts to discuss lab results for nail clippings taken 6 weeks ago. He initially presented with extensive thickening and discoloration of all the nails on his left foot. His past medical history includes type 2 diabetes and hypertension. Currently well, and his repeat medications include metformin, simvastatin, and ramipril. The lab reports confirms onychomycosis. What treatment should you offer him? Oral terbinafine, topical itraconazole, oral fluconazole, topical amorolfine, foot care advice.
Right. So here we know that now thickening, that is onychomycosis severe form. More than 50%, more than 2-3 nails are involved. Here the first line treatment is directly oral terbinafine. And why it is not topical itraconazole? Because there is no topical itraconazole. Why is it not oral fluconazole? Because oral fluconazole you give only if you're suspecting candidiasis, nothing else. And topical amorolfine, good option. I told you topical is a good option, but less than 50%. And if it is 1 or 2 nail involvement, then you can give, or else it is only oral terbinafine, right? You see, very bad, mild infection, no problem. Topical is fine. When it becomes medium or severe, like in the picture, you have to go for the oral. Can someone quickly read about this, please? 27-year-old.
27-year-old woman who is 34 weeks pregnant present with an itchy, blistering rash over her abdomen. Initially, she had a red rash around her umbilicus, but it later spread. What is the most likely diagnosis? Pemphigoid gestation, seborrheic dermatitis, polymorphic eruption of pregnancy, HERP syndrome, pompolix.
Right. Okay. So I will tell you what is this lesion. So you have to know there are certain conditions that are occurring only in pregnancy. Pregnancy, it actually increases. So this condition, actually, can I go to the next? Okay, I'll anyway tell you. So here, if you see, there is this kind of a plaquey lesion that is starting from the umbilicus. So anything in the third trimester, starting from the umbilicus and then goes away, everywhere else, small plaques starting from the umbilicus is pemphigoid gestations. That is the answer here. So second option, why isn't it seborrheic dermatitis? No, these are not the areas for seborrheic dermatitis. So this is not the answer. Third thing, polymorphic eruption of pregnancy. I'll just show you the next picture, right? Seborrheic dermatitis, I told you this is not the picture. Second picture is polymorphic eruption in pregnancy, which can occur again in second or third trimester, but it will spare the umbilicus. You see, the umbilicus is so normal, but it starts from the sides, from the flank. You get this striate-like lesions starting from the flank and going around the body, but sparing the umbilicus, it's polymorphic eruption. If the umbilicus is affected, then it is pemphigoid gestations. Why isn't it pompolix? Pompolix doesn't occur in the abdomen. It is occurring in the hands. It is a variant of eczema, where in the hands, in the fingers, you get small papules and you get, vesicles, water-filled sacs, itchy, just like this. See, the person has itched, and finger webs or the finger spaces. This is called as pompolix, which is also not in the abdomen. So it is out of the picture. Can someone quickly till the 6? Anyway, forget about this. We anyway discussed about acne, so we can answer. It's actually, yeah. Next, can someone quickly read about this, please? A 24-year-old man comes to you. Quickly, somebody.
A 24-year-old man
Yeah.
comes to see you concerned regarding recurrent painful lumps and boils in the axilla and groin region for several months. The patient has previously seen dermatology and was diagnosed with hidradenitis suppurativa. On examination, there are multiple small painful nodules in the axilla and groin region. Heart rate is 68. Tympanic temperature is 36.4 centigrade. You suspect recurrent hidradenitis suppurativa. What is the next most appropriate management step?
Right. Okay. So you know that it is a recurrent hidradenitis suppurativa, and see the first option, commence the patient of topical steroids, is wrong. This is an infective one. We don't give steroids. It can make it worsen. Number two, commence the patient on topical clindamycin for 3 months. Yes, that is an answer, because oral or topical long term for 3 months is the treatment for recurrent hidradenitis suppurativa. And number three, commence the patient on topical retinoids. I wouldn't tell it's an answer, because retinoids are usually given in acne. This is not acne, right? Okay. Inform the patient the only cure is surgery. No, we can actually refer to the dermatology for oral or topical treatment, but surgery is not the only option. And commence the patient on emollients. No, emollients are given in conditions like psoriasis or eczema to reduce the itching and to make it wet, to make it, moist, but not in this condition. This condition is a chronic, painful, inflammatory skin disorder, slowly leads to nodules, pustules, papules infected under your, where's that? Yeah, under your axilla, and becomes scarring, and more common in women than men, and more common in people under 40 years. Risk factors like smoking, obesity, diabetes, family history, all these things can be a cause. And you need to, I'll talk about only the important MCQ points. Long term, you have to give oral antibiotics. There's no any option. Either oral doxycycline or limicycline or clindamycin, like in this case. Okay, right. And then, okay, 1 second. It is 10:03. No, Dr. Sindhupa, are you here? One second. I'll give a. Dr. Sindhupa, are you here? Yeah, hi. So, what actually I was thinking was, 1 minute, just a minute, give me a minute. Yeah, okay. So you can see me, right? So, I mean, totally, I think I have around 70 MCQs, okay? Those 70, if you read, you don't need to actually read anything. That is the only dermatology in your entire exam. You don't have to read anything. I did around 35, I think 50% is done. I have another 35 MCQs to do. I didn't want to overload you with a lot of information, because then you'll be very confused, because up to now, whatever you read, please, try to go home and get the recordings and try to, what do you say, listen to it again and again. And we can have the remaining 35 MCQs again on another day. Because why I prepared this entire thing is, I thought if you just read this, that's enough for dermatology. You don't have to read anything, because I worked very hard going through all the nice guidelines, all the your past papers, everything, and I've compiled these MCQs. So if you're okay with it, Dr. Sindhupa will actually message you on your group, and if you want to have one more class, I can finish the next 35 MCQs, and 70 or 80 is done. That's about it in dermatology. Itaning ehata, you don't have to read anything. So yeah, Dr. Sindhupa, you're there, right?
Yes, Prem. Yes.
Okay, so yeah. So that's about it, Dr. Sindhupa. So
Yeah,
I've
thank you very
explained.
much, Prem. I think I am sure they learned a lot, and because
Hope you learned,
one
yeah.
thing is you covered so many things, and other thing is you are a very good teacher.
Thank you.
So let's see the possibility of having another session, Prem. Thank you
Yeah,
very
yeah.
much.
Thank you, Sindhupa. Thank you.
Okay.